Good morning, everyone. Welcome to another episode of CPD Weekly Webinar Program. Today, we have an interesting topic, which is hypertension in pregnancy. Before moving on to the lecture, let's go to see some housekeeping rules. The webinar link will be available from 9 a.m. to 9:45 a.m. for you to join. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points. And the CPD points are strictly adhered to the NCCPD guidelines. I advise all of you to keep your cameras and mics turned off during the lecture. If you have any questions during the lecture, please type in the chat box and change your settings visible to all the attendees. Now let's move on to the lecture. Today's topic is hypertension in pregnancy. Before moving on to the lecture again, I would like to give a brief introduction about the today's guest lecturer, Dr. Shamitha Dassanayake. Dr. Shamitha Dassanayake obtained his primary education at Maliyadeva College, Kurunagala, and graduated MBBS from University of Sri Jayawardhanapura in 2002. He obtained MD Medicine in 2010 and MRCP UK in 2016. He was trained in geriatric medicine and internal medicine in UK. He was elected as a fellow of the Royal College of Physicians and Royal College of Physicians of Edinburgh in 2019 and the American College of Physicians in 2020. He is a board certified specialist in general internal medicine attached to the Ministry of Health and is currently working at North Colombo Teaching Hospital, Ragam. He was awarded as the most innovative outstation physician 2013 by the Ceylon College of Physicians and awarded as most innovative service improvement project by Sri Lanka College of Internal Medicine in 2018. He served as Honorary Joint Secretary of the Sri Lanka College of Internal Medicine in 2018 and Honorary Joint Secretary of the Ceylon College of Physicians in 2021. His research interests are mainly in maternal medicine and vitamin D deficiency. Sir, over to you to conduct your timely and informative lecture. Thank you.
Good morning to you, everybody. First of all, I would like to thank Sri to inviting me to do this presentation today under the topic of hypertension in pregnancy. And the next hour or so, I would like to discuss about hypertension in pregnancy, mainly the introduction, that is mainly the importance of why this topic is, and the various definitions: chronic hypertension, gestational hypertension, pre-eclampsia, severe pre-eclampsia and eclampsia, postpartum period and breastfeeding, and future developments, and a brief summary. When come to the introduction, the importance is high blood pressure in pregnancy is the commonest non-communicable disease prevalent in pregnancy state. It affects about 1 in 10 women in pregnancy state, and it's considered the blood pressure of 140/90 or more. And under this category, 20% of these pregnant mothers are having pre-existing or this is chronic hypertension, and 80% of them are having de novo, that is either gestational hypertension or pre-eclampsia. It is very important to going through these definitions. I'll take one by one. The hypertension in pregnancy is called blood pressure of more than 140 in systole or higher, or 90 diastole or higher. Severe hypertension means a blood pressure of 160/90 or more. The chronic hypertension is defined as hypertension that is present at the booking visit or before 20 weeks of pregnancy, or if the woman is already taking antihypertensive medication when referred to maternity care. It can be primary or secondary in etiology. The gestational hypertension is new hypertension presenting after 20 weeks of pregnancy without significant proteinuria. Pre-eclampsia is defined new onset of hypertension that is over 140/90 after 20 weeks of pregnancy and the coexistence of one or more of the following new onset conditions. The conditions are: first one is proteinuria, is urine protein creatinine ratio of 30 milligrams per millimole or more. If you are going through the albumin creatinine ratio of 8 grams per millimole or more, at least 1 gram per liter, that is 2 plus on dipstick testing. And it should be associated with other maternal organ dysfunction. Those are renal insufficiency, that is creatinine of 90 micromoles per liter or more, or if you are going through the milligrams, it's 1.02 milligrams per 100 ml or more. Other liver involvement, that is elevated AST and ALT of 40 with or without right upper quadrant or epigastric abdominal pain. Neurological complications such as eclampsia, altered mental status, blindness, stroke, clonus, severe headache, or persistent visual scotoma. When you're going through the hematological complications such as thrombocytopenia, that is platelet count below 150,000 in microliter, disseminated intravascular coagulation, that's DIC, or evidence of hemolysis. The other one is, the last one, is a uteroplacental dysfunction such as fetal growth restriction, abnormal umbilical artery Doppler, waveform analysis, or stillbirth. And when we come to the definition of eclampsia, is called a convulsive condition associated with preeclampsia. The severe preeclampsia means is preeclampsia with severe hypertension, that is blood pressure of more than 160 by 110, that does not correspond to treatment, or associated with ongoing or recurring severe headache, visual scotoma, nausea or vomiting, epigastric pain, oliguria, and severe hypertension, as well as progressive deterioration in laboratory blood tests such as rising creatinine or liver transaminases, or falling platelet count, or failure of fetal growth or abnormal Doppler findings. As you know, now you know about the definitions. Now we will going to discuss one by one. When it comes to the chronic hypertension, I'll go through the definition again, is called, that is present at the booking visit or before 20 weeks, or if the woman is already taking antihypertensive medication when referred to maternity services. It can be primary or secondary etiology. In clinical practice, we encounter several patients in 4 main categories. One is, you may encounter a lady with, sometimes they are coming to see the risk of assessment, the assessment of the risk of having high blood pressure in pregnancy, or it may be due to some other non-communicable disease. Basically, they want the risk, whether they are having a safe pregnancy or they can have complications secondary to non-communicable disease, including high blood pressure, diabetes, asthma, and so on. And the second category is newly diagnosed hypertensive patients with fertility wishes. They want to get pregnant, and now you have diagnosed newly with having high blood pressure. And the third category is chronic hypertensive patient with fertility wishes. This patient is already diagnosed with high blood pressure on treatments, but they are still having the fertility wishes. And the fourth category is a pregnant mother with chronic hypertension on treatments. So if a lady comes to you with a pre-pregnancy assessment, it is very important to take a proper history and examination. First, you should know the age, because if that lady is less than 40 years of age and found to have high blood pressure, then she comes under the category of young hypertension. And also, you have to go through history of subfertility, and further whether there are any previous miscarriages, and currently what are their plans, whether they are planning for fertility treatments like IUI or IVF, and so on. Apart from that, you have to go through the past medical history, actively looking for whether the patient is having evidence of diabetes, kidney disease, autoimmune diseases, and so on. And also the family history is very important, and you can go through the family history of see whether any non-communicable disease within the family, including hypertension and other NSAIDs. And it's important to take the drug history. Right? Some of the patients might take painkillers like NSAIDs, which can cause blood pressure to go up, and also in long-standing NSAIDs usage make some problems with the kidney diseases. And also sometimes the steroids, say somebody with a connective tissue disorder or due to other reasons, patients might be on steroids, which is also can cause blood pressure to go up. And the other aspect of history taking is that occupational history. Right? Some of the patients can have a continuously under stress because of the occupation. So psychological stress, and also sometimes they don't have much time even for sleep. So those are important factors that contribute for the high blood pressure in pregnancy as well, because they won't change the occupation just because they become pregnant. And psychological assessment is important, right? Sometimes they are under the stress, they can have depression, they can have anxiety symptoms, and they can have some sleep disturbances, as I said earlier. And psychologically, it's important to assess about their psychological status before embarking on the pregnancy or the treatments of fertility. And if you think that patient needs basic investigations to confirm whether the patient is having evidence of hypertension or any other non-communicable diseases, of course you need to go ahead and do these investigations before planning for a pregnancy. And the second category of patients that are newly diagnosed hypertensive patients with fertility wishes. Now there's a lady, now we have already diagnosed with high blood pressure, and you should have a proper history and examination in pregnancy point of view. So if the patient is telling that they want to having wishes to become pregnant, then you need to have a proper history and examination, as I discussed earlier. And you should have a proper discussion with the patient or the relevant partner. Then you should have explained the condition, because hypertension is a long-standing high blood pressure and is a lifelong diagnosis. So you have to tell the patient that this is a lifelong diagnosis and the patient should continue the medications and long term, and should need to follow up in the long term as well. And we have to discuss about the pregnancy plans as well. And the other important aspect is, if this newly diagnosed patient of less than 40 years of age, then you have to decide this patient needs the young hypertension workup. So in this type of a situation, it's always better to refer this patient to a specialist care, because sometimes some of these investigations unable to do during pregnancy. As an example, right, if this patient needs, sometimes the patient needs CT abdomen. So the CT scan is unable to do during pregnancy, and sometimes patient might need the CT angiogram. So because of those reasons, it is very, very advisable to go through all the investigations or young hypertension category before embarking on this pregnancy. And when you are coming to the starting of treatments, now this patient is newly diagnosed and you want to start the treatments. So there are a few aspects, and this important aspect is that you need to advise that patient the angiotensin converting enzyme, ACE inhibitors or angiotensin receptor blockers, ARBs, increase the risk of congenital abnormalities. And other way around, that discuss alternative treatment if the patient is ACE inhibitors or ARBs are being taken for other condition, example as renal disease. Sometimes a patient might be on ACE inhibitors or the receptor blockers because of the proteinuria or some sort of a kidney disease. So in those situations, you need to have a discussion with the patient and discuss and for the alternative treatment options available for the plan of pregnancy. And again, you have to tell the patient that thiazide or thiazide-like diuretics may increase the risk of congenital abnormalities and neonatal complications. And you have to discuss about the alternative hypertensive treatment for planned pregnancy. So the bottom line is that you are unable to give ACE inhibitors or the angiotensin receptor blockers or the thiazide-like diuretics or other diuretics during pregnancy or patient who is having a pregnancy plans. And also you need to inform them that the other antihypertensive treatments have not shown an increased risk of congenital malformation, but the evidence are limited. When you come to the newly diagnosed hypertension patient with a fertility wishes, so what are the drugs of choice? The recommendation is you need to think about starting labetalol first. But the problem of this labetalol, sometimes this drug is not available in the government sector. If you are going for the private sector, and it's a bit of expensive. Sometimes you might be able to start with a low dose of labetalol, but later on the requirement will go up and the patient needs to spend a lot of money on taking these medications as outpatient or from the outside pharmacies. And if if any reason, if you are unable to give labetalol for a patient, then better to start with a nifedipine. This is a cheaper drug with a good control. And if you are unable to give both, then the third option available is the methyl dopa. And after starting the medications, then you need to advise the patient about the follow-up plans till she gets pregnant, because this patient needs to be followed up, and also she should advise that her target blood pressure is 140 by 90 or below, and needs to regularly follow up, probably once a month, or depending from the conditions that she is suffering with. And but the follow-up plans is very, very important, and we need to advise the patient not to stop medications because of the pregnancy plans, and you need to continue, and there's no risk of continuing with these medications during the pregnancy period even. Now, the third category of patients are these patients are already diagnosed with high blood pressure or the chronic hypertension, presenting to you and coming and say that they become pregnant. So you have to go through the blood drug chart and see whether the patients are on ACE inhibitors or ARBs. So if the patient is on ARBs or the ACE inhibitors, you need to stop antihypertensive treatment, and preferably within 2 working days of notification of pregnancy, and offer alternative treatments. And as I said earlier, the alternative treatments, not one and the other, like apart from the ACE inhibitors, ARBs or thiazide-like diuretics, and the other medications, the antihypertensives, won't show much of a problem in continuation. And you can continue with the existing antihypertensive treatment if it is safe in pregnancy, or switch to an alternative treatment. That is, like the patient is not on labetalol, not on nifedipine, or not on methyl dopa. You can switch to these drugs because they are safe in pregnancy, and you can continue until the postpartum period also, provided that her systolic blood pressure remains more than 110 and the diastolic pressure of above 70, and this patient should not have symptomatic hypotension, because if the patient's blood pressure is less than 110 by 70 or having systematic hypertension, then you should not continue with these medications. You should stop antihypertensives and observe and need regular monitoring. So, and the other patients, sometimes patients are diagnosed with chronic hypertension, but they are not taking medications because of the anxiety that because she became pregnant. So, if a pregnant lady with a chronic hypertension presenting to you, who have chronic hypertension, who are not already on treatments, so you need to check the blood pressure, and if there is a sustained blood pressure of 140 by 90 and above, then you need to start with the treatment. When using medicines to treat hypertension in pregnancy, aim for target blood pressure of 135/85 or below. So you need to start, if you need to start treatments if the blood pressure is more than 140 by 90 in pregnancy, and your target blood pressure is to keep the blood pressure less than 135/85. So if the patient is not on treatments, as I said earlier, you need to consider labetalol or to treat chronic hypertension in pregnant women, and nifedipine, and also the methyl dopa as a third choice, and base the choice on any pre-existing treatment, side effects profiles, risks, including fetal effects, and the women's preferences. Sometimes you might say that patient is having severe wheezing or the asthma in the past, and sometimes the labetalol might triggering with this asthmatic condition. So you have to have a discussion with the patient and decide what is the best drug for her. This is very important finding, important to say that if a pregnant mother with chronic hypertension need to start with aspirin 75 to 150 milligrams once daily from 12 weeks onwards. This is very important. So any patient with any pregnant mother with a chronic hypertension, after 12 weeks of pregnancy, you need to start with the 75 to 150 milligrams of aspirin if there's no real indication, there's no real contraindication to starting aspirin. And during the pregnancy period, if the patient is having if you think the patient is having a risk of pre-eclampsia, and there's a new investigation is called the placental growth factor based testing to help rule out pre-eclampsia between 20 weeks and 30 weeks of pregnancy if women with chronic hypertension are suspected of developing pre-eclampsia. And also, it's very important to advise about the lifestyle. Now this patient with a pregnancy having chronic hypertension, you always advise about the weight management, exercises, healthy eating, and also lowering the amount of salt in their diet. I will come back to the salt intake in the pregnancy later on as well. Now the patient was diagnosed and we are having a pregnancy and we are continuing with the pregnancy and come to a conclusion about the timing of birth. What are we going to do about the delivery of this lady? So the guideline says do not offer planned early birth before 37 of weeks of pregnancy to women with chronic hypertension whose blood pressure is lower than 160 by 110 unless there are other medical indications. So you should not plan for an early delivery if the pregnant mother's blood pressure remains less than 160 by 110 and there's no any other medical indications to go for a emergency section or the early delivery. For women with chronic hypertension whose blood pressure is lower than 160 by millimeter after 37 weeks, with or without antihypertensive treatment, timing of birth and maternal and fetal indications for birth should be agreed between the woman and the senior obstetrician. So it's a two-way conversation between the mother and the VOGs to decide considering the maternal factors, fetal factors, and come to a conclusion at what point that we are going to deliver the baby. If due to any reason, if you have planned early delivery, then you need to consider about giving a course of antenatal corticosteroids. Usually we are using dexamethasone and magnesium sulfate if indicated in the line with the guideline on preterm labor and birth. So there are various guidelines we are following, maybe nice guidelines, maybe local guidelines, but if you are deciding to take the baby out before 37 of week pregnancy, then you need to give the corticosteroids, that is dexamethasone and the magnesium sulfate if indicated. And after delivery, that is postpartum period, immediate postpartum period, you need to measure blood pressure daily for the first 2 days after birth, then at least once between day 3 and day 5 after birth, and afterwards as clinically indicated if antihypertensive treatment is changed after birth. Sometimes we are continuing the same medication, sometimes we are changing to some other medications of the antihypertensive treatment. So whatever the situation, postpartum, the target blood pressure should be lower than 140 by 90. So we have to maintain the blood pressure of 140 by 90, and also we need to advise the patient, right? She needs to check the blood pressure on and off, and to keep the blood pressure less than 140 by 90 for a period of 6 weeks up to 42 days. And we need to continue the antihypertensive treatment if required. Sometimes we may be able to change the medications, or sometimes we might be able to come down with the treatment doses, but whatever it is, if you are continuing the antihypertensive treatment, and sometimes you need continued treatment to maintain the blood pressure less than 140 by 90. Then offer a review of antihypertensive treatment 2 weeks after the birth with their specialist, usually 2 weeks, 4 weeks and the 6 weeks. And this is also important because this is some of the confusional statement that if a woman has taken methyl dopa to treat chronic hypertension during pregnancy, stop the methyl dopa within 2 days after the birth and change to an alternative antihypertensive treatment. This is very important because sometimes the patients from the very beginning they are on methyl dopa, but after delivery you need to stop the methyl dopa within first 2 days, and if the blood pressure is high, then you need to change over to other alternative antihypertensive. Then we'll come to the second stage of this lecture is about the gestational hypertension. Gestational hypertension is defined as new hypertension presenting after 20 weeks of pregnancy without significant proteinuria. And again, the hypertension is called between 140 by 90 and above, but is less than 160 by 110. And severe hypertension is considered as blood pressure of more than 160 by 110 or more. This gestational hypertension is not usually accompanied by fetal growth restriction. So this is important. Sometimes the pregnant mother will ask from you, right? Now I am having gestational hypertension. What is the outcome of the baby? So we can say not usually. It's not usually accompanied by fetal growth restriction. But outcomes in pregnancy normally good, but approximately 25% will go on to develop preeclampsia, particularly if less than 34 weeks, and have poorer outcome. So what are the risk factors? The risk factors for gestational hypertension is that nulliparity, age 40 years of older, pregnancy interval of more than 10 years, family history of pre-eclampsia, and multifetal pregnancies like twins or triplets, etc. Other risk factors include BMI of 35 or more, gestational age at presentation, previous history of preeclampsia or gestational hypertension, pre-existing vascular disease or pre-existing kidney disease. Again, this is very important that any patient with gestational hypertension, we need to monitor this patient, and if the patient is having a high risk of preeclampsia, now this patient is still in the gestational hypertension period, but if you think the patient is having a high risk of preeclampsia, as I said earlier, you need to start with the aspirin, 75 to 150 milligrams of aspirin daily from 12 weeks until the birth of the baby. So women at high risk are those with any of the following. Those are hypertensive disease during a previous pregnancy, chronic kidney disease, autoimmune disease such as systemic lupus erythematosus or antiphospholipid syndrome, type 1 or type 2 diabetes, that is also important, or a patient with chronic hypertension. And the people are using various medications during pregnancy, but they should not use the following to prevent hypertensive disorders during pregnancy. One examples are like nitric oxide donors, progesterone, diuretics, or low molecular weight heparin. And also about various nutritional supplements some people are recommending during pregnancy, but you should not recommend the following supplements solely with the aim of preventing hypertensive disorders during pregnancy. Those are magnesium, folic acid, antioxidants like vitamin C and vitamin E, fish oils or algal oils or garlic. Mind you, this is about hypertension, but there may be some other indications to prescribe folic acid and so on during pregnancy. And about the diet, and it's very important to tell that do not recommend salt restriction during pregnancy solely to prevent gestational hypertension or preeclampsia. So even in the pregnancy, you need to ask the pregnant mother to cut down salt or reduce salt if that patient is diagnosed with hypertension, but not otherwise. And the low salt diet is not recommended in a view of preventing gestational hypertension during pregnancy. And come the lifestyle, give the same advice on rest, exercise and work to women with chronic hypertension or at risk of hypertensive disorders during pregnancy as healthy pregnant women. When come to the management of gestational hypertension, the management is, there are two aspects. One is watch and wait, that is blood pressure of 140 by 90 and less than 160 by 110 can be managed as an outpatient with once or twice weekly blood pressure measurements. So this is very important. Someone who is having a blood pressure of more than 140 by 90 but less than 160 by 110 can be managed at home, but needs to check the blood pressure frequently. And urine dipstick, weekly bloods, and placental-like growth factor testing and 2 to 4 weekly ultrasound for fetal assessment is important in patient with gestational hypertension. And consider pharmacological treatment if blood pressure remains above 140 by 90. So if a patient with gestational hypertension and blood pressure of more than 140 by 90, then the patient should be on treatments. And labetalol or nifedipine or methyl-dopa is a drug of choice as we discussed earlier. And if a patient with gestational hypertension having severe hypertension, that means the blood pressure of more than 160 by 110, then that patient needs immediate admission. But after admission and treatment, if the blood pressure is coming down, you can manage that patient as a hypertensive patient. But if the patient, when you are looking the patient, when you are examining the patient, if the blood pressure of more than 160 by 110, that patient needs admission. And offer treatment, you need to start with the treatment and record blood pressure every 15 to 30 minutes until the blood pressure has dropped to 135, 85 or below. And you to continue with the pharmacological treatment. In this patient needs daily urine dipstick urine in patient testing and also measurement of full blood count, urea and electrolytes, liver function test at presentation, then weekly, and carry out placental growth factor testing and also the fetal assessment. About the gestational hypertension, now the issue is of the timing of birth. These patients with gestational hypertension also do not offer planned early birth before 37 weeks if the blood pressure is lower than 160 by 110, unless there are other medical indications. If birth is necessary, offer steroids and magnesium sulfate in line with the guidance on preterm labor. There's no difference between the chronic hypertension and the gestational hypertension in that sense. When compared with the watch and wait and also the treatment, 2 in 10 will develop severe hypertension and 47 of admissions to the NNU. That is, you are not starting treatments and you are watching. But when the treatment, if the blood pressure is more than 140 by 90, if you are started on treatments, then 1 in 10 patients went to the severe hypertension and only 23% of admissions to the NNU. In a country like this, we have a lot of lack of facilities. It's better to start with the treatments if you detected the blood pressure of 140 by 90 in a pregnant mother. Then we'll come to the third aspect of this presentation is about the preeclampsia. Preeclampsia, I have defined preeclampsia in previous slides. Now the preeclampsia, why it is important is that preeclampsia is a complex medical disorder associated with over 500,000 fetal and neonatal deaths and over 70,000 maternal deaths globally each year. And these patients with preeclampsia can deteriorate rapidly and without any warning. And preeclampsia may develop or be recognized for the first time intrapartum or early postpartum in some cases. So that is very, very important, because sometimes we are discharging patients at home and the patient might develop preeclampsia at home. Then no one is knowing what's really going on. That is the important, because the preeclampsia can happen or can occur first time after the early postpartum period. And this is very important. Other finding is that proteinuria is not mandatory for a diagnosis of preeclampsia. In that definition, I said 1 or more. So proteinuria is not mandatory for diagnosis of preeclampsia if you can come across with the other positive findings under the definitions of this preeclampsia. And what are the risk factors for preeclampsia is that there are some moderate risk factors as well as high risk factors. The moderate risk factors for the preeclampsia is first pregnancy, age 40 years or older, pregnancy interval of more than 10 years, BMI of more than 30 kilograms or more at first visit, family history of preeclampsia, and multiple pregnancies. When it comes to the preeclampsia with high risk factors, the risk factors high, the hypertensive disease during a previous pregnancy, or chronic kidney disease, autoimmune disease such as SLE, that is systemic lupus erythematosus, or antiphospholipid syndrome, type 1 or type 2 diabetes, and chronic hypertension. So those are considered as high risk for developing preeclampsia. And it's important, 2 or more moderate risk factors or 1 or more high risk factors is enough to diagnose of preeclampsia. And giving aspirin of 75 to 150 milligrams per day for 12 weeks until birth, that is also important. Then we come to the timing of birth in a patient with preeclampsia that needs record maternal fetal thresholds for planned early birth before 37 weeks in women with preeclampsia. It's important for maternal fetal thresholds for planned early birth before 37 weeks in women with preeclampsia. When come to thresholds for considering planned early birth could include, but not limited to, any of the following known features of severe preeclampsia. That is, inability to control maternal blood pressure despite using 3 or more classes of antihypertensives in appropriate doses. So if you can't control the blood pressure of the mother with three medications with appropriate doses, then it becomes a 1 threshold. And the maternal pulse oximetry less than 90%, and progressive deterioration in liver function, renal function, hemolysis or platelet count. And fourth one is ongoing neurological features such as severe intractable headache, repeated visual disturbances, or placental abruption, reversed end diastolic flow, abnormal CTG, or stillbirth. And these patients offer intravenous magnesium sulfate and a course of antenatal corticosteroids if indicated, if early birth is planned for women with preterm preeclampsia in line with the guideline on preterm labor and birth. And your target blood pressure is to bring down less than 135/85. And the post-delivery of preeclamptic patients, Preeclampsia should be considered at high risk for preeclamptic complications for at least 3 days and should have their clinical condition monitored at least every 4 hours while awake. And it is important to note that eclamptic seizures may develop for the first time in the early postpartum period. You should avoid NSAIDs, that is non-steroidal anti-inflammatory drugs, for postpartum analgesia in preeclampsia and AKI. If the patient is having preeclampsia and having evidence of acute kidney injury, and you should not use NSAIDs for the prevention of pain. And there are some other, this is a little bit of advanced, there are some prediction models. I'm not going to do these details. There are some full pairs, PrEP-S and placental growth factor. Those are can be used as a prediction models for the assessment and prevention and treatment of preeclampsia. The last part of this one about this classification is severe preeclampsia or eclampsia. So if someone who is having a severe preeclampsia or eclampsia, that is a patient having severe preeclampsia with fitting, the patient is developing the seizures now. If a woman in a critical care setting who has severe hypertension or severe preeclampsia has or previously had an eclamptic fit, give intravenous magnesium sulfate. So that's the indication to start with the intravenous magnesium sulfate. Consider giving intravenous magnesium sulfate to women with severe preeclampsia who are in a critical care setting if birth is planned within 24 hours. That is also important. If the team is deciding to go for the delivery within next 24 hours, it is important to give the intravenous magnesium sulfate. It's because of the severe preeclampsia or eclampsia. And consider the need for magnesium sulfate treatment if one or more of the following features of severe preeclampsia is present. So these are the indications to give magnesium sulfate. One is ongoing or recurring severe headaches, visual scotomata, nausea, vomiting, epigastric pain, oliguria and severe hypertension, progressive deterioration in laboratory blood tests such as rising creatinine or liver transaminases or falling platelet count. This is very important for everybody, that how are we going to give the magnesium sulfate. Magnesium sulfate is given as a loading dose of 4 grams intravenously over 5 to 15 minutes, followed by an infusion of 1 gram per hour maintained for 24 hours. So that is, we are giving a loading dose of 4 grams or 5 to 15 minutes, followed by an infusion that is 1 gram per hour maintained for a period of 24 hours. If the woman has had an epileptic fit, the infusion should be continued for 24 hours after the last fit. So since the last fit, you need to continue the magnesium sulfate 1 gram per hour for 24 hours. And if the patient is developing recurrent fits, should be treated with a further dose of 2 to 4 grams intravenously over 5 to 15 minutes. So now you have treated with a loading dose and you are continuing the maintenance dose. Even with the maintenance dose, if the mother is going to develop another epileptic fit, then you can repeat another dose of 2 to 4 grams of this patient. And again, it's important to say that after this 24 recurrent fits should be treated with a further dose of 2 to 4 grams given intravenously over 5 to 15 minutes. But you need to continue the intravenous 1 gram per hour from the last fit for a period of 24 hours. And this is very important, that do not use diazepam, phenytoin or other anticonvulsant as an alternative to magnesium sulfate in women with eclampsia. So what are the drugs, antihypertensives available for patients with preeclampsia and eclampsia? Treatment with a severe hypertension who are in critical care during pregnancy or after birth immediately within one of the following. That is labetalol. You can give it oral or intravenous, oral nifedipine or intravenous hydralazine. When come to the fluid balance and volume expansion, do not use volume expansion in women with severe preeclampsia unless hydralazine is the antenatal antihypertensive. In women with severe preeclampsia, limit maintenance fluids to 80 ml per hour unless there are other ongoing fluid losses, for example hemorrhage. HELP syndrome, that is hemolysis, elevated liver enzymes and low platelet counts. And this is important to say that do not use dexamethasone or betamethasone as a treatment of HELP syndrome. So there's no indication to give dexamethasone as a treatment of HELP syndrome. Finally, then we'll come to the postnatal period and the breastfeeding. Advise women with hypertension who wish to breastfeed that their treatment can be adapted to accommodate breastfeeding, and that the need to make antihypertensive medication does not prevent them from breastfeeding. Offer Enropil to treat hypertension in women during the postnatal period with appropriate monitoring of maternal renal function and maternal serum potassium. For women of Black African or Caribbean family origin with hypertension during the postnatal period, consider antihypertensive treatment with nifedipine or amlodipine if the woman has previously used this to successfully control her blood pressure. And for women with hypertension in the postnatal period, if blood pressure is not controlled with a single medicine, then consider a combination of nifedipine or amlodipine with enropil. If this combination is not tolerated or is ineffective, consider either adding atenolol or labetalol to the combination treatment, or swapping one of the medicines already being used for antenatal for atenolol or labetalol. Swapping of 1 gram of the medicine, swapping of one of the medicines already being used for atenolol or labetalol. Where possible, avoid using diuretics or angiotensin receptor blockers to treat hypertension in women with postnatal period who are breastfeeding or expressing milk. That is important for the postnatal period, and these patients need to follow up. If the patient is having chronic hypertension, then patient needs regular follow up. But if the patient is having a gestational hypertension, sometimes the pressure might back to normal after 6 weeks or after 42 days, but you need to regularly follow up to see the outcome of these pregnant mothers. Then we'll come to the future developments of pre-eclampsia and the eclampsia. Is the main role of placental growth factor in pre-eclampsia. I have mentioned several times that to do the placental growth factor in a diagnosing and managing of eclampsia, pre-eclampsia or severe pre-eclampsia. So what is this? This is a new technique that we are using in the management of this pre-eclampsia. This placental growth factor is a member of the vascular endothelial growth factor family and is predominantly expressed in the placenta. It is also expressed at low levels in many other tissues including the heart, lung, thyroid, liver, skeletal muscle and bone. This is a picture of this placental growth factor, molecular picture. And there are there are 4 tests. I am not going to in detail of these tests. There are various tests, and the placental growth factor test, PLGF test, is the commonly used one. Is an increasingly important molecule in the prediction, diagnosis and treatment of preeclampsia. So the placental growth factor is used. It's important to say that it's for the prediction, diagnosis and treatment of preeclampsia in mothers with hypertension. So about the evidence. The trial evidence says the committee considered the evidence of PARROT and INSPIRE trials which assess placental growth factor based test as part of a clinical algorithm that included using the test alongside clinical judgment to make decisions about care. The model that they have used is if the placental growth factor is more than 100, then the patient was discharged and managed at home. If the placental growth factor is more than 12 but less than 100, then patient should be under continuous surveillance. And if the placental growth factor is less than 12, that patient needs admission. And this placental growth factor was used for the follow-up after the post-delivery for review as well. The advantage of placental growth factor is that it reassures pregnant women with hypertension who are anxious about complications and risk to the baby and themselves. Because sometimes the mother is worried about the outcome of the baby and the mother if the mother is having high blood pressure during pregnancy. And also it's important for screening for high risk groups for preeclampsia. This is basically screening test. So someone who is having a gestational hypertension or chronic hypertension, you can go ahead and do this test to see whether the patient is carrying a high risk for preeclampsia. And the third one is improve risk assessment and enable early planning for a safe birth. Because if this test can be done in a hospital and we can plan for a safe birth, because we can go ahead the risk assessment. And also it's helped to avoid stressful last minute medical interventions. Sometimes there may be various interventions in the last minute in medical point of view in a patient with preeclampsia or eclampsia. So we can avoid by doing this test. Women at centers without facilities for preterm baby care can be safely transferred to a suitable equipped centers in good time. Because if this positive, the placenta growth factor is positive and you are expecting preeclampsia or eclampsia, you can transfer these pregnant mothers to a tertiary care center in advance after informing the relevant authorities and that we are transferring this patient with this suspected preeclampsia. And also it's better identification of women who will not develop preterm preeclampsia, reducing unnecessary hospitalization. So this test can be used to reduce the unnecessary hospitalization uh, because of the suspected preeclampsia or eclampsia. Benefits of using this test for shared decision making. So this is important for the physician, VOG, neonatologist and the rest of the team. When come to the clinical effectiveness of this test, that PLGF based test results should be used alongside clinical information for decision making. PLGF based testing did not lead to unnecessary early births in UK trials. There was a concern that this testing can lead to unnecessary early births, but the trials shown in UK doesn't support this finding. When come to the maternal outcomes, its evidence from trials suggests potential improvement with PLGF based testing and better decision making about care. About the neonatal outcomes, the effect of PLGF based testing is uncertain, but some evidence suggests it may improve decision about care. There are some Delphi Express tests have established rule in and out. It's something called rule in and rule out thresholds, but the other test did not give this cutoff. Repeat PLGF based testing evidence is still limited. So we really don't know whether there is a benefit of doing a repeat PLGF in patients suspected of preeclampsia. When come to the limitations of this testing is about the cost and the availability. So the cost is very high. Even in the UK the cost is high. So it's very difficult for us to use this test in day-to-day activities, but this may be the future. And research is needed on test cutoffs for women pregnancy with more than one baby. So there are no laid down guidelines or the cutoffs for multiple pregnancies. If a twin or a triplet or so on, there are no cutoffs for the time being. And there are no international standard reference materials for PLGF testing. So it should be in future and it's evolving and needs the international standards for the usage of the PLGF testing. Finally, we will come to the summary of this presentation. And very briefly, there are few points I need to highlight. One is any pregnant mother with a sustained blood pressure of more than 140/90 needs treatment. And any pregnant mother with a blood pressure of more than 160/110 needs admission. Proteinuria is not essential in diagnosing preeclampsia, and the magnesium sulfate is a drug of choice in managing eclampsia, not the other medication including the diazepam or the benzodiazepines. And PLGF will play a major role in future in management, diagnosing and prognosis in preeclampsia in patients with gestational hypertension or chronic hypertension. So this is the newest guidelines. That was the this guideline was edited on 17th of April this month 2023, and and I have used the national guideline as well as references. Thank you.
Thank you, dear sir, for your very informative and timely lecture. I think all of you got a great idea about how to manage the hypertension during the pregnancy. It is a common topic we encounter in our day-to-day clinical practice. So let's move on to the question section. At the moment, we have two questions in the chat box. What is the correlation with the placental growth factor and the hypertension in pregnancy? I think sir described it very well during the last few slides. The
Yes.
next question sir, is what is the correlation with uric acid and severe preeclampsia?
Yeah, this is very important, and we need to have a good idea about the physiology during pregnancy. Right, there are various physiological changes during pregnancy, and during pregnancy, the EGF or the kidney function will improve or increase, and we are expecting lower levels of uric acid during pregnancy. But if someone's uric acid is going up, that means there's a breakdown of cells because purines and the breakdown of the cells, and that will increase the purine levels and ultimately end up in uric acid. So if the uric acid levels are going up, that uric acid may affect the maternal dysfunction, maternal dysfunction, placental as well as the fetal. So basically, it will affect the maternal endothelial dysfunction. And the placental outcome is also there because it acts on the placenta and sometimes and causing the blood pressure to go up. And also the fetal outcome is death. So it's not a reason, it's a basically it's a correlation that if the uric acid levels are high, that's indirectly indicate that the patient is having a risk of pre-eclampsia or going into the pre-eclampsia. And that is important for the other way around also. When we are treating for the high blood pressure and if the mother's blood pressure is coming down, then we are monitoring the uric acid levels, whether because of the high blood pressure or the pregnancy, the pre-eclampsia, there's a various cellular destruction. Cells will break down and giving treatments, this cell destruction will reduce. And because of that, the uric acid levels will come down. So most of the time, we are monitoring the uric acid to see as a response for the treatment for preeclampsia. So if the uric acid levels are coming down, that we know, right, now this patient is responding and these physiological changes within the body is getting better. So it's not a causing agent, but it's a parameter that we are looking for indirect ways whether the patient's outcome in preeclampsia.
Right. Okay, sir. The next question, so can we stop Maxalfate 24 hours after the delivery? I think,
Yes. Now, there are some indications, right? If you are planning to give magnesium sulfate, we need to give the loading dose, and you can continue the maintenance dose for 24 hours. But if the patient has developed another seizure during the maintenance dose of preeclampsia, then we need to continue 24 hours after the last seizure. So that while on maintenance, the patient has developed another seizure. And from that point onwards, we need to continue for another 24 hours. But giving another loading dose is basically it's a multi-system. Basically, it's a the team decision. But you can repeat once. If you really think the patient needs a loading dose of magnesium sulfate 4 grams, then it's a team decision to give another single dose of repeating another single dose of 4 grams in magnesium sulfate because magnesium sulfate can become toxic. So we have to monitor everything. The renal functions, the blood pressures can have the risk of arrhythmias and so on. And the guideline says you start with the loading dose and you can repeat a loading dose only once afterwards. But if the patient develops seizures during the maintenance dose, then from the last seizure, you need to continue 24 hours of magnesium sulfate for that.
okay, sir. There's another question with preeclampsia and eclampsia. How do we decide whether it's oral or IV labetalol? What's the factors that decide the route of administration?
Yeah, it depends on now you are having whatever the situation that we are treating for a patient with preeclampsia or eclampsia, your target blood pressure is to keep the blood pressure less than 130 by 85. That is your target. So somehow you need to bring the blood pressure to that level. So, and when you're comparing the nifedipine and the labetalol, now newer studies says the labetalol will give a smooth control compared to the nifedipine because sometimes nifedipine may have some fluctuations. Sometimes the drastic pressure will drop. So, but when you compare to the labetalol has a smooth control of blood pressure. And in these situations, we can use the IV labetalol. So that if the blood pressure is high and we need to bring it to less than 135/85, then ideally we can go for the IV labetalol to get that to the bring it less than 135/85. So whether we are giving for the oral medications or whether we are going to the IV medication, it depends on the requirement because somehow we need to bring it 135/85 and also the availability. Some of the hospitals, there won't be any IV labetalol. So we have to go by the labetalol, nifedipine, and so on. So there's no hard and fast rule whether we should ideally, is it essential to give IV labetalol? It's not. Sometimes maybe in some other hospitals, IV hydroxyzine will be the available drug in clinical practice. So we have to use that, but somehow we need to bring the blood pressure of 130/85 or below.
Okay, sir. There's another question. If the gestational hypertension is diagnosed after 20 weeks, is aspirin is indicated in such patients?
Yes, because now the gestational hypertension, I had given some of these saying what are the indication or the risk factors for develop gestational hypertension patients. There are sets of risk factors saying that this patient might go into the preeclampsia. Right? If you think this patient is at high risk of going into the preeclampsia, even though at the moment the patient is gestational hypertension, you better need to start with aspirin because we are diagnosing this patient as gestational hypertension after 20 weeks, right? So we need to start with aspirin if the patient carries a high risk of going into the preeclampsia.
So there's another very interesting question. So if a patient with a background of fits, I think he's meaning epilepsy, who presents the seizure on the background of high BP, then what's the management?
Yeah, it's now there are various anti-epileptic medication that we are using, right? Sometimes we are changing into the carbimazole and carbamazepine and so on. But having a seizure, then you have to establish whether the patient is hypertension first, right? Because without hypertension, if the patient is going to develop seizures, there may be various other reasons. It may be hypocalcemia, it may be hyponatremia, or it may be hypoglycemia. So, and because when you are addressing the seizures during pregnancy is very critical, then if the patient is having hypertension and having seizures, then you need to think whether we are dealing with a eclamptic fitting. And it's always better to rule out the other because we are dealing for a pregnant mother and we say that somebody is having a hyperglycemia and then and there you need to correct it because that will otherwise the patient is going to the permanent brain damage. So that's it's important. And if the patient is having high blood pressure and developing seizures is important. But mind you, even with the normal blood pressure, the patient might develop the eclampsia. That is also true. So it's a collective decision with the team, all the TL members, whether you agree with this and this thing. But always it's better to give the magnesium, right? Because the diazepam and the other anticonvulsants are not indicated in managing of preeclampsia or eclampsia during pregnancy.
Right. Okay. Any of the other questions you have already answered in the lecture. Then again, I would like to thank Dr. Shamitha Dassanayake, sir, for your valuable time in spending us on you spent on giving us this lecture and your the information you gave us during this lecture and the very interesting answers you gave during the question and answer section. So I would like to again thank Dr. Shamitha Dassanayake, consultant physician, North Colombo Teaching Hospital, Ragama, for his excellent lecture and his precious time. And I would like to thank everyone who joined with us today during this lecture. And I like to invite all of you to go through the link which is in the chat box and give your details to receive your CPD certificate. And I invite all of you to join with us in the next week also with another interesting topic in the Sri Knowledge Academy CPD webinar series. Thank you very much and have a nice day.
Thank you so much.